We are talking about inflammation now. So, inflammation is a response, a local response to tissue injury. What happens is that when something has happened, if the tissue has been injured, remember the first topic we discussed was tissue injury, cell death. So, if there is an injury to a tissue, there's going to be a response by the immune system. The aim of that response is actually because when an injury happens, maybe there are microorganisms that can cause infection at that region. So white blood cells have to come in so that they can be able to prevent, okay, to react to that cellular injury or to that injurious agent. It's actually a form of defense mechanism against any agent that comes from outside the body. Inflammation, you are going to see it ends in itis, for example, pancreatitis, mastitis, but not absolute. You also have pneumonia, which is basically the respiratory system. If there are infections there, you are failing to clear the infection. So the inflammation of the respiratory system, that would be pneumonia. What causes inflammation? Can have infections. Infections are caused by microorganisms like bacteria, viruses, parasites, and fungi. Radiations can as well cause inflammation. Physical and thermal agents, trauma, burns, okay. Also, frosty bite. This is where it happens when there is very low temperature in exposed areas. For example, if the ear or the nose has got very low temperature, inflammation can happen. Immunological reactions, fractures, toxic substances, all these can cause inflammation. Inflammation has got what we call the cardinal signs: swelling in so you can see we have got the English term for the swelling, and then we have got these Latin terms. Swelling, also known as tumor, that is one form of inflammation. A cardinal sign of inflammation, there are five, you need to know them. Redness, which is also known as rubor, okay, that is, just think of ara rubor, that's redness. And then the portion where inflammation is happening is going to be warm, that's known as color. Okay, color, think of calories, that is to mean energy or heat, and that is, of course, heat is what causes warmth. And then pain or dolor, and then a tissue that has undergone inflammation can go into loss of function, that's known as functio laesa. So please know these five cardinal signs, both the English and the Latin. These signs of inflammation can appear on the surface of the skin and may also happen in internal organs, like in acute appendicitis. There are also systemic signs of inflammation. Those were cardinal signs. Systemic signs. So systemic means what happens in the entire body. If someone has inflammation, what is going to happen? There's going to be fever, and this fever is actually caused by chemical mediators of inflammation. We're going to talk about them. There will be chills, malaise. Malaise is you just not feel, you just don't feel fine. Like you don't know the cause, but you just don't feel fine. Increased fatigue, okay. And then there's can also be vomiting in kids. Increased erythrocyte sedimentation rate, increased level of what we call the C-reactive protein, which is this C-reactive protein activates complement. So you actually see that in inflammation, there are some proteins that increase, some proteins decrease. So we'll talk about that later on. C-reactive protein is one of those proteins that increase because it activates complement, which helps to fight infections. We have got two types of inflammation: acute inflammation and chronic inflammation. Acute inflammation starts suddenly, right? And it can within minutes to hours. The many cells in acute inflammation are the neutrophils. Chronic inflammation, chronic, it is over a period of time. It's not sudden. Acute means sudden. Chronic means over a long period of time. So it will happen over a long period of time, and the main cells of chronic inflammation are the monocytes and macrophages. This table is very easy, very simple like this. Your test one, they can just bring differentiate chronic inflammation from acute inflammation using a table 10 marks. Okay. And then in acute inflammation, there's going to be tissue injury, but it is self-limiting. The tissue injury is not very bad. While in chronic inflammation, tissue injury is going to be very severe and it will be progressive, it will go on. How about the local and systemic signs? The systemic signs are very prominent. Acute conditions are bad. Like for example, asthma. Asthma is acute, so it will just happen like that. Bush, it attacks you. So the signs, the local and systemic signs are very prominent. While for chronic inflammation, because it's there for a long period of time, it's like you have adapted. You've now known it. You've now used. So the systemic and local signs are less prominent. Okay. So that is that. And then the general features of inflammation we need to know. Inflammation is a defensive host response to foreign invaders and necrotic tissue, but it's is itself capable of causing tissue damage, because actually what leads to death is to the extent in which the body responds to try to protect us. And the main components of inflammation are vascular reaction and cellular response. Please take note. You have got the vascular. You are going to have things that will be happening to the blood vessels and what the cells will be doing. Actually, this can come as an essay in test one, right, about the vascular reactions of inflammation or cellular responses of inflammation. So what happens if someone has got acute inflammation? The aim after the end of acute inflammation is that that stimulus, that noxious stimulus should be removed, or there can be decline of the reaction and there's going to be repair of the damaged tissue where inflammation was happening. Or the acute inflammation can actually go into chronic inflammation. Now, this doesn't mean that acute inflammation always goes into chronic. Chronic inflammation can also go into acute inflammation. For example, you are going to discuss later on in what we call the chronic myeloid leukemia. It can go into acute. So something has been there for long and then it can become acute. Acute means it becomes an attack that is just sudden and then someone can end up dying. What are the steps of inflammation? So the steps of inflammation can be represented by 5 R's. Number one, there's going to be recognition of the injurious agent. Please know these, right? Know them. You are going to recognize the injurious agent. And then when you recognize this injurious agent, what you are going to do is you are going to recruit leukocytes, which are the white blood cells. The aim of recruiting these white blood cells is to remove the agent. And then after you've removed the agent, there should now be control of the response, because if it becomes abnormal, it will become bad to us. And then after there is regulation of the response, now there should be tissue resolution. There should be resolution or repair. Okay, that tissue where the injurious agent was, or that place, there should be now repair happening. But in this class, we'll not talk about repair. We'll discuss repair in the next class, tissue repair. So cells of inflammation, as we said earlier on, neutrophils are the main cells in acute inflammation, while macrophages and monocytes are the main cells of chronic inflammation. Basically, in chronic inflammation, we have got the lymphocytes, like the B cells and the T cells, also the plasma cells. But take note, the neutrophils are the main cells of acute inflammation. So let's talk about acute inflammation. Acute inflammation, from the word acute, this is inflammation that happens suddenly, just happens suddenly like that. And for this one, what is going to happen is that there's going to be an increase in blood flow to a body part. Because of an increase in blood flow, that region is going to appear red. Okay, because blood is red, right? So there's going to be redness. And actually, a lot of blood to a region will cause that region to become warm. And what happens is that when these when blood has gone to a region very much, there's an increase in hydrostatic pressure. Hydrostatic pressure is the pressure that removes things from the blood vessels. Because of that increase in hydrostatic pressure, contents of within the blood vessels start leaving. That causes edema. Okay. So this is what happens in inflammation. Number one, there's an increase in blood flow. Number two, things start leaving from the blood vessels that causes edema. And number three, first water was just leaving, and now cells will also start leaving, like the neutrophils will start leaving the cells to go to that region where there's inflammation. So we said that the many components of inflammation, we have got vascular reactions and cellular response. So we are specifically discussing acute inflammation. The first thing we need to understand are the vascular reactions that are, so what happens to the blood vessel in acute inflammation? So you need to know of these like five things that happens or four things that happens to the blood vessels. Number one thing that will happen to a blood vessel once there is an inflammation is there's going to be a transient vasoconstriction. Transient means that it's happening just for a very small period of time. It's just passing. So where that region where there's a tissue injury is going to vasoconstrict. The aim is so that blood doesn't go very much to that area, and this is a brief reflex constriction of the blood vessel. And because there's this constriction, meaning that blood is not going enough to this region, and what is going to happen is that the area there is going to turn pale yellow, and that's known as the blanch. Okay, so there's blanching on this transient vasoconstriction. The next thing that happens is now there's going to be persistent progressive vasodilatation. Remember, this was constriction. Now there's vasodilatation. The blood vessel will now become big, and this one is persistent. And this vasodilatation is because of the inflammatory mediators like the histamines. And what happens is that there's increased blood flow to the area. Because of this, there's going to be the area looking red, which is the rubor, as a feature of acute inflammation, and there's going to be warmth there, which is the calor. So once that has happened, there's now going to be an elevation of local hydrostatic pressure, the pressure that causes things to leave the blood vessel. You can see this hydrostatic pressure going out like that. The pressure that holds things in the blood vessels, that is known as oncotic pressure or osmotic pressure. So hydrostatic pressure has increased, that will cause fluids to start leaking out of the blood vessel. Please, the fluids, all right, and that leads to what? Transudate edema. Transudate edema is a type of edema where it's fluids leaving, fluids. Please take note of that. Not cells, but fluids. The next phase is now going to be an increase in vascular permeability. So what will happen is that, remember, the blood vessels are surrounded by endothelium. So those endothelial cells, which are special epithelial cells, squamous cells of the blood vessel, will start now having some space between them. So gaps are formed on the endothelium in response to histamine and the kinins. And because of those gaps, what will happen is that white blood cells will now start leaving the blood vessel. When the white blood cells are leaving the blood vessels, what happens is that leads to exudate edema. Exudate is different from transudate. Transudate, there are no cells, it's just water leaving. And then exudate is cells are also leaving the blood vessels, and this is because of an increase in vascular permeability. So you can see here again, this is a very nice diagnosis. The normal, what happens is that hydrostatic pressure should be equal to the colloid osmotic pressure. Pressure holding things in the blood vessel should be equal to the pressure that is removing things from the blood vessels. So in exudate, what happens is that you can see there is an increase in endothelium. So can you see this is an endothelium, this is an endothelium? There is a big space between them. So what happens is that proteins start to leak out, and many other types of cells like the white blood cells and red blood cells, and that's what leads to exudate edema because of increased interendothelial space. And then in transudate, you can see the endothelium is still attached, so it's actually only water that is leaving. Okay, only water that is leaving, only water. And in transudate edema, what happens is that there is actually an increase in hydrostatic pressure. That's why you can see this blue arrow is very big, and there's a reduction in colloid osmotic pressure. You can see that's why the gamma green arrow is very small. So here, no, a lot of proteins are leaving the cell, and only few cells are also leaving, not leaving the cell, but leaving the blood vessel. Okay. So, what contributes to the increase in vascular permeability? Why is it that a lot of contents are leaving, like the cells and the proteins are leaving the blood vessel? It can be because of endothelial cell contraction. When the endothelial cells contract, they will start creating gaps between themselves. And that's actually the major reason as to why a lot of things leave the blood vessels. It can happen rapidly in response to histamines, bradykinin, leukotrienes. And what happens that when these guys bind to this endothelium, they will now cause the endothelial cells to contract. This is short-lived, and a prolonged contraction can happen. It is due to a prolonged contraction. Okay. All right. So a prolonged contraction is going to be because of the contraction of cytoskeleton. And this one is going to be because of the tumor necrosis factor and interleukin 1. Otherwise, the histamine, bradykinin, leukotrienes, these ones cause only a small contraction which is short lived, it's not prolonged. Another thing that increases the removal of things from the blood vessels, increases vascular permeability, is just direct endothelial injury. If the endothelium has been injured, there can be spaces and things start leaving. There can also be increased transcytosis of proteins, like the proteins are leaving the cell on those junctions, epithelial junctions, okay, because of response to certain mediators like the vascular endothelial growth factor. They can also be, let's say, when new blood vessels are forming, those are a bit of weak, and so things can be able to leak from these new blood vessels. So those are known as vascular events in inflammation. They can bring you an essay in the exam, right, about the vascular events of inflammation. Please take note of that. And then the cellular events, what will be happening to the cells. So now the cellular events is just talking about the cells leaving the blood vessel. So for the cells leaving the blood vessel, the first is that is known as the leukocyte extravasation, extravasation or recruitment. Leukocyte is because it's the white blood cells that are leaving the blood vessels that we're interested in. The first thing is known as margination. Normally, what will happen is that this is the inside of a blood vessel on top here. You can see the leukocytes are normally moving on the sides, of course, here like that. But in margination is the leukocytes will now come, they start moving near the endothelium. That's known as margination. So leukocytes move towards the vessel and line up against the endothelium. Because normally what happens that because the red blood cells are small, the red blood cells are going to be moving on the middle of a blood vessel, and then the white blood cells are a bit on the sides. But in margination, what happens is that they even go more, they are pushed out of the central axial column, like on the middle, to go to the very end so that they start interacting now with the endothelium. That's margination. Once margination happens, there's now going to be rolling. Rolling, what happens is that now they are small, they are these weak and transient. Transient means that it's just uh, ongoing, like it will happen and then stop. So they are weak and transient interactions. These white blood cells will now be forming bonds which are weak and transient with the endothelium, specifically with what is known as the selectin family of adhesion molecules. Okay, so here can you see this is the white blood cell. On the endothelium, you have got the selectins, you have got the P selectins, you have got the E selectins. Actually, on the same white blood cell, we are going to also have what we call the L selectins. What you need to understand here is what do these P selectins and E selectins bind to on the red blood cell. I mean on the white blood cell. Can you say that on the white blood cell we have got what is known as the sialyl Lewis X modified glycoprotein? So this is sialyl Lewis X modified glycoprotein will actually be binding to the P selectins. Okay, it will be binding also to the E selectins, and that is what leads to rolling. So it will bind a bit, the bond breaks, it goes like that, the bond forms breaks just like that. But the L selectins are not found on the endothelium. Instead, they are found on the actual white blood cell. So what happens is that the L selectins will bind because the L selectins are found on the, please, this will come in your test or your exam. So, actually your test. So P selectin and E selectin are found on the endothelium, and they'll be binding to the sialyl Lewis X modified protein. But L-selectin is found on the white blood cell, and it binds to what is known as glycam 1. The glycam 1 is on the endothelium, right? That's where it will be binding. Hope that makes sense. So that is how rolling is going to be able to happen. After rolling happens, now you'll be forming much stronger bonds because in rolling you are forming weak bonds. So adhesion will happen. Adhesion, these are much stronger bonds, and they are mediated not by selectins but by integrins. Okay, integrins are found on the white blood cells. The integrins will be able to bind to their ligands on the endothelium. For example, you have got on the endothelium, you have got what is known as ICAM 1. This one is on the endothelium, it's a ligand. It will be able to bind to what is known as the MACI1, which is an integrin, which is found on the white blood cell. On the endothelium, again, you have got what is known as VCAM1, which binds to VLA4. This can come in multiple choice questions. What does this bind to? ICAM1, it is to MAC1, and then VCAM1 to VLA1. Just remember VCAM, VLA1, 4. And then ICAM to MAC. Okay? Just take note of that. Because you can see this is ICAM. You just change the ICAM, start from the end mark, but even the vcam, it is all you can change to mark, but then because of the v, that's why the vla, so that can help you to remember. So adhesion is you forming much stronger bonds, a much stronger bond, so that the white blood cell can fully attach to the endothelium and it will not be able to move. After that happens, the next step will be what is known as diapedesis, also known as the transmigration. I forgot to write a T there. Transmigration. Transmigration is where the white blood cells are now passing. The white blood cells, you can see this was margination and then rolling and then adhesion, stronger bonds with the integrins, and then diapedesis or transmigration is now the white blood cell is now leaving the blood vessel going into interstitium. You can see it is passing through the endothelium. And what mediates this is known as PCAM1. The goodness is PCAM is found on both endothelium and on the white blood cell. So there's not much mastering there. Okay, PCAM is what mediates diapedesis or transmigration. So that is what happens once this white blood cell crosses the endothelium. What it will happen is that it will now secrete collagenases, because in interstitial tissue you are going to have collagen, so that you can be able to break down this collagen so that the the white blood cell can pass through the basement membrane which contains the collagen. Okay, so that is what is going to happen once the white blood cell is now in the interstitium. It is now going to release chemokines. Chemokines are substances that will be able to attract other white blood cells to where this one is. Okay, it will release the chemokines, and that is known as chemotaxis, which is migration in the interstitial space. So both exogenous and endogenous substances can be chemotactic. They can be bringing leukocytes. For example, you have got bacterial products like the N-formylmethionine termini cytokines. Please take note of this, interleukin 8. This can come in your multiple choice. And also the complement system, you have got C5a. Please take note, C5a is also a chemokine, okay, to also attract leukocytes. You also have leukotriene B4. So I don't want you to forget leukotriene B4, C5a, and interleukin 8. These can act as chemokines attracting other neutrophils, other cells. Of course, it's neutrophils because it's the acute inflammation for this one. Once this cell have reached to where the injurious agent was, there's now going to be phagocytosis. These leukocytes are going to, remember, neutrophils act as phagocytic cells, are now going to be able to phagocytose that offending agent, kill the microbe, and then degrade the tissue that was necrotic. So we have got different chemical mediators of inflammation which are responsible for these vascular events and the cellular events that we've just discussed. And these chemical mediators can be produced by the cells or they can be found in plasma. They are produced from the liver. So cells that can produce these chemical mediators include lymphocytes, platelets, macrophages, basophils, endothelial cells, mast cells, and then those which are found in plasma are produced by the liver. So you can see the cell derived, please you need to know this, please you need to know this. Those mediators that are derived from the cell, which come from the cell, we can divide them into two. There are those that are released already formed, preformed mediators, and they are found in secretory granules, and also those which are newly synthesized. They are not already formed, they have to be synthesized when they are being released. So they already formed, you have got histamine, which is released by mast cells, basophils, and platelets. This guy is actually important in also asthma. There's also serotonin, which is released by platelets. So please take note of also the cells releasing them. So you only have two which are preformed. Your exam there, your test one. Those which are newly synthesized, you have got the prostaglandins, which are released by all cells, leukotrienes also by all cells, especially mast cells. These guys are actually going to be involved in bronchoconstriction. That's why they are going to be important in asthma, because asthma, the bronchioles become small, and what does, that's actually the leukotrienes. You also have the platelet activating factor, which is released by the endothelial cells and all other cells. Reactive oxygen species like superoxides, hydrogen peroxide, those things, they are going to be released by or white blood cells. Nitric oxide, this is a vasodilator. It dilates the blood vessels. It's released by macrophages and the endothelial cells. Cytokines also, like the interleukins, the tumor necrosis factor released by macrophages, lymphocytes, endothelial cell, mast cells. And then you also have neuropeptides, which are released by the white blood cells and also by the nerves. Okay, so this is just now describing these different types of inflammatory mediators released by the cell and their function. Histamine causes increases vascular permeability, so it will cause vasodilation. Serotonin does the opposite to histamine. It causes vasoconstriction. It plays a very important role in coagulation, stopping blood clot. Platelet activating factor will cause also vasodilatation like histamine. Chemotactic in nature also. Reactive oxygen species, these guys are there to kill microbes like the superoxides. We also call them free radicals. Superoxide, hydrogen peroxide, and the hydroxide. Nitric oxide, I said it is a vasodilator just like the histamines and the platelet activating factor. It's also used in killing microbes. Cytokines, these are known as mediators of inflammation. They're the ones that mediate inflammation, like tumor necrosis factor and the interleukins. For example, tumor necrosis factor, TNF, interleukin 1 and interleukin 6. These are the major interleukins in acute inflammation, while interleukin 12 is important in chronic inflammation. Chemokines are any substances which will be able to attract white blood cells to the site of inflammation. So it will include any cytokine that will do this function. Prostaglandins are involved in three functions. They cause pain, vasodilatation, and fever. That's why we'll discuss this very well in pharmacology also, when we'll be talking about treatment for pain and the use of NSAIDs and like aspirin. Leukotrienes, these guys increase vascular permeability. Of importance, remember we talked about leukotriene B4, which is a chemotactic agent which attracts neutrophils to the site of inflammation. And then you have got those plasma protein derived mediators. They are not coming from the cell. Here you have got only two: the complement system, the complement proteins, and what we call the kinins. So the complement proteins come from the liver. There are 20 proteins. You know, you have got the classical pathway, alternative pathway, the mannose binding lectin pathway. All these pathways will lead to the production of the complement proteins. C3A and C5A, these are anaphylatoxins. They are going to stimulate mast cells to release histamine. Remember, C5A is a chemotactic factor. Okay, C3B is an opsinin. It makes the microorganism sweet so that the phagocytes can chew it properly. It surrounds the microorganism. C5B to C9, this is known as a membrane attack complex mark, so it is used to break down the cell. The kinins, important kinin you need to know, especially is bradykinin. Of course, you also have calidin, but the most important is bradykinin. These are vasodilators. Bradykinin itself is also a pain stimulant. It causes pain. So where there's an injury, you see bradykinin produced there so that you can feel pain, and increases the vascular permeability. So what happens if someone had an acute inflammation? What will be the end result? The end result of acute inflammation is either forming an abscess. An abscess is where you have got basically a, uh, a pus filled. Pus is representing white blood cells. You have got a structure that has been filled by pus. Okay, or filled by white blood cells. You can even break it and then you are going to see these yellowish things coming out. Those are actually white blood cells. That's an abscess. And so that's one outcome of acute inflammation. Please, you need to know these outcomes. And then acute inflammation can actually also lead to complete resolution. Like the injurious agent can be removed and then everything is back to normal. It can also lead to healing, where a scar can be formed because of fibrosis, like fibroblasts are going to come in, lay there, and then that leads to this healing with a scar. Acute inflammation can also go into chronic inflammation. Therefore, we now should understand chronic inflammation. Chronic inflammation can be defined as prolonged inflammation, which takes weeks or months, where an active inflammation, tissue destruction, and attempt to repair are proceeding simultaneously. So we've seen what is happening. There is tissue destruction, and at the same time, there are attempts to repair what the problem that is there happening at the same time. What can cause chronic inflammation can be persistent infection that have been there for long, they can't go away, prolonged exposure to non-degradable but partially toxic substances. You can't degrade them and they are toxic. Okay. Either endogenous lipid components, which can cause atherosclerosis, an increase in lipids in the blood vessels, or even exogenous substances like silica, asbestos. These can all cause chronic inflammation. Chronic inflammation can also just come from acute inflammation. They can also be autoimmune diseases like, for example, rheumatoid arthritis, systemic lupus erythematosus. This can cause chronic inflammation. Now you have got some conditions that don't start as acute inflammation, they just start as chronic conditions. So you need to know that. Okay. Classification of chronic inflammation. It can be non-specific chronic inflammation, which involves the diffuse accumulation of macrophages. Like macrophages that accumulate on the lymphocytes at a site of injury that is usually productive with new fibrous tissue. For example, chronic cholecystitis. That is non-specific. In specific inflammation, we call this as granulomatous inflammation because there's going to be a way in which the cells are going to arrange themselves properly. So there is a characteristic of a granuloma where you are going to have epithelioid cells. What is an epithelioid cell? It's just a macrophage that has been activated. And because it looks like an epithelial cell, that's why we call it epithelioid cell. These epithelioid cells can also fuse together and they are going to form what we call giant cells, which have got a lot of nuclei, multinucleated giant cells. So this is how a granuloma looks like. Okay, you can see for the picture, but take note of the cells. On the middle, you are going to have epithelioid macrophage. You can see the way they've changed the shape, and then some of them have joined, they have formed these multinucleated giant cells. And then you also have dendritic cells, presenting cells. We've got also neutrophils. Surrounding these cells, you can see now you have got the lymphocytes. After the lymphocytes, now you have got fibroblasts. That is what forms a granuloma. So this is a granuloma. Please take note of the cells that you'll be able to find, right? So you have got two types of giant cells: foreign body type giant cell. These are irregularly scattered nuclei in the presence of indigestible material. So you have got material that you can digest, and then you have got these big cells that are surrounding them. And then Langerhans giant cells, here the nuclei are arranged peripherally in a horseshoe pattern. And they are going to be seen in someone that has got condition like TB, sarcoidosis. Giant cells are formed by fusion of macrophages, as we said earlier. So, what are the major causes of granulomatous inflammation? What can cause chronic inflammation? Because if we say granulomatous inflammation, that is basically chronic inflammation because that is a feature, right? So, bacterial infections can cause granulomatous inflammation, for example, TB, leprosy, syphilis, cat scratch disease, yersiniosis. This is caused by Yersinia pestis. This is bad. You are going to understand this in pathology. These are very bad diseases. And then fungal infection like histoplasmosis, cryptococcosis, coccidiomycosis, blastomycosis. Fungi, these guys have got bad names to pronounce also, but yeah, these are fungi. You can also have worms, helminths, like schistosomiasis, protozoa, like leishmania and toxoplasmosis. And then chlamydia, this is also a bacteria like lymphogranuloma venereum. Inorganic materials like berylliosis can also cause granulomas, and others which we don't know, for example, acidosis, just having acid, a lot of acid. Disease. Crohn's disease is where we've got accumulation of what is this hormone? So there's an accumulation of an endocrine hormone, okay, and then primary biliary cirrhosis. So there's a problem with the ciliary system there. The biliary system, this is where you have got a connection to the liver is going to send its products via the bile duct, and that is going to go and connect with the cystic duct. Actually, you have got hepatic duct, cystic duct, that forms the common bile duct. So that's the biliary tract. So there's a problem there also. Okay. So these are the major causes. So what are the systemic effects of inflammation? If someone has got inflammation, what are you going to see in the entire body? You are going to see fever. Fever is because of the interleukins which are released, and this will stimulate the hypothalamus to start releasing a lot of heat. Endocrine and metabolic responses. So what will happen is that the liver will start now secreting what we call acute phase proteins. Some of the acute phase proteins are known as positive acute phase proteins because they increase. For example, the C-reactive protein increases. Others are known as negative acute phase proteins because if there is inflammation, they will reduce in number. Okay, please take note of those two. Positive acute phase proteins increase in number, negative acute phase proteins reduce in number. You should find out examples. There can also be autonomic responses like the redirection of blood flow from the cutaneous to deep vascular bed. From the skin, blood should go more to the deep vascular bed. And then behavioral responses can be seen like rigor, chills, anorexia, someone doesn't want to eat, somnolence, you can't sleep, like you are dozing in the daytime, malaise, just feel not okay. Leukocytosis can also happen. Leukocytosis is the increase of the white blood cells. Most bacterial infections will induce neutrophilia. Neutrophilia is an increase in neutrophils. Bacterial infections. Some viral infections, like infectious mononucleosis and mumps, can cause lymphocytosis, the increase of the lymphocytes. Okay, so take note, leukocytosis is the increase in leukocytes, white blood cells, but white blood cells are a lot. If you have increased neutrophils, you call it neutrophilia. Increase the lymphocytes like B cells and T cells, we call that as lymphocytosis. The reduction of these, you are going to call it penia. You are going to put penia, like neutropenia, that is low. Parasitic infections and allergic reactions, what you are going to see being high is eosinophils. So leukopenia can also happen where you have got reduced white blood cells, like for example in typhoid fever and some parasitic infections. Weight loss can as well get to happen, okay, because of the interleukins that are produced. Please make sure that you know the systemic effects. And essay can come right about the systemic effects of inflammation 10 marks. So that is it, my friends, on the inflammation as a topic.